what's up, everybody? This is Maggie Reichart, and you are listening to Nursing Uncharted, a podcast that explores different types of nursing by talking to ambassadors of their fields. If this is your first time listening to the show, welcome, and thank you so much for listening today. And if you are one of our avid listeners to Nursing Uncharted, I really appreciate your continued interest, and I've really appreciated the feedback that I've gotten so far from you all, so thank you. We have a great topic today, something that I think many nurses have thought about, once or twice in their career when they think about advancing their practice and going back to school, and that is nurse anesthesiology, or going back to be a CRNA, which is a certified registered nurse anesthetist. So here to give us a rundown on all things CRNA is Blaise Sims. Blaise has been a CRNA since 2014 and currently works as site chief in the Houston Gulf Coast region. His nursing background includes a myriad of critical care environments, including neurotrauma ICU, medical ICU, surgical ICU, cardiac ICU, and ER. His CRNA career started in a heart and vascular institute, working in heart, lung, and kidney transplants, as well as major aorta and vascular procedures. In 2020, Blaise graduated with his MBA in order to better understand the business side of healthcare and anesthesia, and is a leader among his peers. He mentors new CRNAs by creating educational resources that help guide them through their first few years. Blaise also created a charity that sends surgical teams abroad to bring critical care resources to surgical centers in need. Blaise is married with 2 children and resides in Houston, Texas. So Blaise, welcome to the show. It's great to have you here.
Thank you for having me on. It's a pleasure.
Yeah, I feel like I don't have any friends that are CRNAs, so I feel like all of my questions are going to go to you.
That's great. That's why we're here.
Yeah, right,
exactly.
So did CRNA, was that always the end game for you? Did you know you always wanted to be CRNA?
For the most part, it was. I always I was always interested in kind of challenging myself and
Sure.
trying to take the next step, stuff like that. And so the end goal of being a CRNA was kind of always in the back of my mind.
Gotcha.
And then
that makes sense since you've done every type of ICU nursing.
Yeah, I used to kind of joke it's like a jack of all trades but a master of none,
right?
If you will, so
Totally. We say that in the medical ICU too, because you have to. I mean, there's so many different procedures and diagnoses and illnesses and stuff. Like in medicine, you just have to know a little bit about everything.
Yeah, definitely. But yeah, to answer your question, being a CRNA was kind of always a part of the plan, if you will.
Cool. Very cool. I want to kind of start at the beginning and then work our way in, meaning start in the beginning of CRNA school, kind of what that's like for listeners that might be interested, in exploring that, and then kind of move into the job itself, and what expectations are there. So can you give me kind of a rundown of what is CRNA school? What is it? What is it like? How long is it? What should people expect?
For sure. So CRNA school is usually anywhere from 28 to 36 months. Okay. I came from a master's degree program. Now, most of those are getting phased out into doctorate programs. The majority of curriculums now have already made that transfer. So that's going to be your 3-year, 36 months education there. Most of the programs are front-loaded with didactics. So you'll do at least a year, maybe even a year and a half of straight book work. And then that'll take a back seat once you start clinicals. And then you usually have 1 to 2 days of didactics related to clinicals. And that will involve something that we all love, care plans.
God, you guys still have to do care plans? Those never go away?
They never go away. I still have dreams waking up in the middle of the night, cold sweat, the care plan.
Yeah. That sucks. Well, okay.
Yeah, no, I wish I had good news. They don't
Yeah.
go away. But yeah, so it's always, it'll be front loaded with the didactics, and then you'll go or transition into more of your clinicals, kind of like, nursing school.
Sure.
Now, I'm not sure how nursing school is today, but one of the good things about CRNA school is you'll have a fairly decent amount of time to transition into clinicals with a lab. And you'll go through mock scenarios and stuff, but it's a little more directed than, say, nursing school checkoffs were.
Okay.
I found that when I graduated from CRNA school, the stuff you learned in the lab was very translatable to actual clinical practice, which was, kind of refreshing.
What would those labs look like?
So the good thing about being a CRNA is it's a lot of the same things in different variations, So if you practice a routine like an induction sequence, and the order in which meds are given, that's not necessarily going to change once you go into clinical practice.
Right.
Now you might start treating somebody with different comorbidities, different risk factors and things like that might alter your anesthetic plan. But for the most part, there's a sequence of events that you can kind of get the muscle memory of that help with the transition into clinicals on the first day.
Gotcha. Okay. So like in lab, you would get a situation like this type of patient with this type of history going for this procedure. Like what sequence or what medications would you give at like the certain doses?
Mm-hmm. Absolutely. And so, you'd be given a scenario, let's say a 35-year-old female for a lap chole. And then talk to me about your anesthetic plan. And they'll give you a little sheet, she's got this airway classification. Okay, that's a good one, so we're not really worried about airway. It should be a normal procedure, normal BMI, stuff like that. But we're going laparoscopic, so once we intubate, we're going to insufflate the abdomen. Okay, what are we thinking as far as laparoscopic considerations? And then you'll kind of stop and you'll kind of go through those. And the first time, it's really kind of like talking through the scenario.
Yeah.
And then as you advance, your simulations get more and more advanced to where this is going on. Okay, we're at this point of the procedure. Now heart rate's dropping. What are we going to do? Okay, didn't respond to that. And they're trying to get you to shift your mind from following orders to deducing through differential diagnosis.
Sure.
And finding the problem on your own and then kind of solving for that problem.
Gotcha. Okay. Wow. Yeah, that's really interesting. So most of would you say, so it's like 3 years of kind of just those, case study situations
it's very
that get
intense.
more complex.
Yeah. And so it's kind of hard. CRNA school is hard in the fact that you're being presented with an overwhelming amount of information, more than anybody can digest, so you just, it's almost like a war of attrition. You see how far you could get to where you're practicing in a safe, effective manner,
Sure. Yeah.
A lot of times in CRNA school, you feel like you're at the bottom of Niagara Falls just trying to drink water. It's just, the information is just calling.
Well, that's interesting that you say that because I read through one of your seminars that you do for new CRNAs coming in, and there was this one comic, a cartoon. It was about like communication techniques for like new CRNAs to talk to old CRNAs, and there's like a wrong way to do it and a right way to do it, and the wrong way to do it was like, I'm going to run circles around you, dinosaur, or something like that. And then there was like, the right way was like, I could learn so much from you. And I thought that was really funny, but it also made me wonder, like, do CRNAs feel, is there like a sense of like real, like confidence and empowerment that comes from getting that degree, or is there still a sense of like imposter syndrome that, a lot of professions have?
Especially starting out as a new CRNA, imposter syndrome is definitely there.
Yeah.
The first day you walk in, you're like, well, this is great. I just have all this debt and I'm going to hurt somebody on my first day. There's no way around it. It's going to happen. It's just a matter of time.
Yeah.
And then you get through that and you're like, okay, I actually do know how to take care of people safely, but
yeah.
I got invited to a party by accident and they're going to find out that I'm here and somebody's going to ask me to leave. And then as you progress in your clinical career, then you get confident, in your abilities. And that, what I tell the young people starting out in their anesthesia careers is confidence comes from proven ability.
Sure.
The more we prove that we can do something competently, we're going to be confident in that.
Yeah.
It's just the same thing with ICU nursing. The first time we've ever hooked a patient up to a CRRT machine, it's like this is Greek, and I don't know how to do any of this. And then afterwards, you're like, no, you don't do that. You hook it up here.
Yeah.
Come on now, you should know that.
Absolutely.
So,
yeah.
Very similar in that regard.
I just recently started doing CRRT a few months ago because I'm like about a year into ICU. And like the first time I had a CRRT patient, our rooms are all window. It's like we have a sliding glass door. And I had like the entire book of like CRT like written all over it like looked like a mad scientist. So I was like, this is what I like need to do. Like I didn't trust myself.
The schematic from It's Always Sunny in Philadelphia to figure out like the
yes. Yeah, that's exactly what it was. People were like, this is a lot of information. Like this is, I hate like those red alarms. I hate those red alarms because I'm like, they're going to clot. Like I need to figure this out. So.
I don't. You're giving me flashbacks here.
Yeah, right. You left ICU nursing for a reason. We want to take a quick break from this episode to talk about the industry leader in travel nurse staffing, American Mobile. Combining the largest network of facilities and providers in the country with top-level benefits like higher earning potential, premium health insurance, and 401k matching, American Mobile puts you in the driver's seat of your travel nursing career. Make sure to visit AmericanMobile.com today to discover a world of adventure with American Mobile. That's AmericanMobile.com, the first step towards your next travel nursing adventure. So you said, okay, so a lot of what are the prereqs? What are those? Are there prereqs, I guess, for...
To go to CRNA school?
Yeah.
So the prereqs would involve graduating with your BSN from an accredited school, doing at least 2 years of ICU. Now, different programs will allow for like pediatric ICU or neonatal ICU, in addition to adult ICU. And then there might be a few kind of odd prereqs that a specific school might want, like an advanced statistics or a specific type of chemistry, but that'll be program specific. But for anybody that's wanting to go to CRNA school, you can go to whatever school's website that you're interested in and look at the curriculum. The prereqs will be listed out. Entry requirements such as GPA, experience, things like that.
Gotcha. Okay.
And that kind of varies from program to program. But if anybody wants specific information about a program near them, you can go to their website and they'll have everything listed out. And, nursing is nationwide, but it's very much or worldwide, but it's very much a small community, and every program that we've ever dealt with, there's somebody in that office that will gladly answer any questions that they have and kind of talk you through the admissions process.
Sure. Yeah, absolutely. Okay, cool. Are there any kind of like common misconceptions when people think about going into CRNA school and then actually getting in? Is there, like they think it's going to be one thing and then it's something totally unexpected?
Definitely. I think that's everybody's experience. because you'll watch somebody that's extremely smooth and efficient and have been doing it for 12 years, and you're like, well, this is easy.
Yeah.
This is very simple. Look at them; they're just handling it. And one of the mentors that I had early on in my career, her favorite saying was, "We're hands-on sometimes, mind-on always." Mm-hmm. And so that's really stuck with me through my career, because there are times where somebody like, well, how did you know that was going to happen? You need to be 3 steps ahead. So understanding surgical procedure in and out, to know where we are. Okay, in 2 more steps, we're going to release a clamp. Okay. I'm going to get a flush of CO2. Okay, I need to go ahead and start over-breathing my patient, have my bicarb ready. What was my last gas? These types of things that you're just going through this mental checklist in your head, but to everybody else, it looks like you're sitting in the chair, kind of looking off in space. Like, oh, they're just relaxing, having a good time. You're like, no. These wheels, it's like
other meme.
Exactly, where the woman's looking off and the algebra equations like going. It's like, that's exactly what's going on all the time. Like, they're so quiet up there. You're like,
they're thinking of all these things.
Yep, exactly.
Okay, wow, yeah. I feel like I'm sure, to nurses thinking about going into CRNA, like all they see is like dollar signs, and then they actually are, actually go, like they're not actually thinking about all of the time and effort and, everything that actually goes into CRNA school specifically. That's what I was thinking when I'm like common misconceptions, because people are, so many people are like, oh yeah, I'm going to do CRNA, not knowing at all that it's, has all of these components and it's like totally life enveloping.
Yeah, I think the thing that's probably the most underestimated is the burden of responsibility and being captain of the ship in the OR from an anesthetic standpoint. One of the big revelations that we all have when we first start out in our anesthesia careers, our first time we get in the OR, the surgeon is operating. Mm-hmm. And then they look at you to keep the patient stable, and you're like, oh, this is in my lap.
Yeah.
This is my responsibility. He can't or she can't be managing the blood pressure. They're working, so that's our responsibility, and I think a lot of people, especially me, you talk about it and then you get in there and you're like, oh wow, no, this responsibility is very much something to take into account when someone's trying to decide, do I have the personality to do this? Do I want to do this and take on that responsibility?
Yeah. It's interesting, just that like little example that you just made about how, just making sure like, vent settings and then giving a push of CO2 and watching their, anticipating bicarb and like doing a gas, like all of those things I didn't really, for somebody that doesn't, talk to CRNAs a whole lot. I think of CRNA as giving anesthetics and intubating and, but there's really so much. You're the one giving all of the medications, right? For like the whole, procedure.
Correct.
Yeah.
So there's a reason why anesthesia schools require you to go to ICU first and have that experience, because it's such an intricate working person's knowledge that if you haven't managed, somebody in DKA before and understand, or extreme heart failure.
Yeah.
Once you get in the operating room and you're presented with those cases, it's anesthetic plus ICU management meshed together.
Yeah.
And you have to be able to put on both hats.
Right.
And understand that what I need from an anesthetic standpoint at this point in time is going to come at the cost of maybe something that I need to account for before I send them to ICU.
Yeah.
Nobody likes, to be dropped off or have a patient that's dropped off that is wide awake and trying to self-extubate before we've even got them hooked back up to the monitor in the ICU.
Right.
You know, so it's understanding those two roles, and you'll see a lot of some of the famous ICUs around the country will actually have anesthesiologists as the critical care attendings.
Yeah.
And there's a reason, or especially surgical ICUs.
Sure.
Because ICU management and surgery really go hand in hand.
Yeah.
So having an intricate knowledge of both makes for your continuity of care to be much more seamless.
Yeah, that makes perfect sense to me.
And it's simple. And it's something that I encourage my young students and CRNAs in our profession to do is go check on your patients in ICU. That's the best feedback you can have. Talk to your ICU nurses.
Yeah.
You know, I never saw anybody do that where I was, but it has, really helped shape my career and how I give anesthesia. If I'm going back in the ICU 2 days later and I'm seeing the same issue with the patient occurring, it's like, okay, well, is that something that I'm doing that needs to be on my radar? Do I need to change my practice intra-op so that this does not become an issue post-op?
Like, give me an example of something that may affect the patient a couple days after.
Vent settings.
Okay.
Okay.
Sure.
You could do something like that where what am I running my FiO2 at? In my mind, 100% FiO2 the whole time during surgery. We're just going to keep this O2 sat at 100%. But am I doing that at the cost of developing atelectasis and then making it where the patient
has nowhere to
might
go?
Might not hit metrics and be able to wean to extubate as soon as they could have.
Sure. Okay. Yeah, that makes sense. What's part of the, what am I trying to say? What assessments do you have at your fingertips while you're in surgery other than, what are you looking at in order to titrate medications? Is it, like you said, gases? You can draw gases, vitals?
So that's one of the parts of anesthesia school is, every day you're putting a new tool in the toolbox. Okay, what does this look like? Everybody's under a drape. You can't see anything. So how do I assess my patient?
Yeah.
And I'm a big advocate of old school assessment. Don't treat the monitor. What if my O2 sat is reading, 50, okay, but it's unplugged, or it came off the finger and it's on the floor, and then I start making these heroic measures, and I didn't, it's the foundation of nursing.
Yeah.
There's a reason why CRNAs are advanced practice nurses. We're all in the same, community coming from the same foundation, and, we, the acronym, we ought to add PI. Assessment, number one, So you start putting those tools in your toolbox and you learn how to assess from an anesthetic standpoint. And it starts with your vital signs, and then you'll learn how to read capnography and look at your CO2 waveforms. You can really, if you had one piece of information for the entire case that would give you the most information, that would be CO2 capnography.
Yeah. I could see that.
So you start seeing, seeing things through a different lens. You put on a different set of glasses that'll kind of let you see. And then with experience, you'll know, okay, my heart rate's going up based upon my anesthetic plan. Is my patient light? Is this a pain response? Are we hypovolemic and this is a compensatory mechanism and I need to give some volume, So you really do process a lot of analytic information from vital signs and things like that.
Yeah.
So that's one way you can assess. The other is getting an ABG. and looking at lab values, acid-base balance, what is my base excess, making sure that my electrolytes are in balance and then we're not having some type of event from an imbalance there.
Right.
And then the other things, if you get into some of the more advanced specialties, like CV, stuff like that, being able to understand TE imagery and what that means for cardiac function, things like that. That's another tool, if you will, to be able to assess your patient while they're asleep and not moving. But that's a challenge. There's a learning curve with that because, but it's not dissimilar to having a vented, sedated patient.
Yeah.
Yes, you can see them and you can see, I can see pitting edema, but like, you just learn to put on a different, set of glasses, if you will, and see it from a different way.
I'm sure too, in your background of transplants, there's so much assessment and imaging and labs and everything that goes in on the back end, like beforehand too, to give you kind of just a, broad idea, like, is this, even able, is this person even, what are we looking at? What is the, what is the TE? Like, what does their echo look like?
Oh yeah. And so that's a big thing is pre-op evaluation. I tell, all of the young CRNAs out there and any students, the best way to get yourself out of a bad situation is to prepare appropriately and not get in it in the beginning.
Yeah.
So that's like a pillar of any good anesthesia provider is a thorough pre-op assessment and plan. If I really talk to this patient, really sift through the chart, pick out certain risk factors and things that are comorbidities that are going to give me problems for a specific procedure, I can have a plan A, a plan B, a plan C, to where if things do go awry or the patient responds in a non-reassuring manner, we've got this equipment already in the room. It's not a panic. We're not, somebody run, go get the glide scope. We're having trouble intubating, right? Well, no, we anticipated a difficult airway. I've got the difficult airway cart right here. Our glide scope is right here. I've got an extra set of hands.
Yeah.
We do a pre-induction timeout. We talk about everything. We go through our plan, make sure we have a redundancy and a backup. So when you talk about like a pre-op evaluation and assessment, that's huge.
When you get hired as a CNA at a specific facility, do you generally work with the same people, same surgeons, same procedures, or like how broad, how much variety would you expect to see in your day when it comes to those things?
It kind of depends. Every anesthesia group is different. Every hospital system is different. It's like you have the same outline for every case. You can almost equate it to being a pilot. Okay, you're gonna take the plane off. We're gonna get to a cruising altitude, and then we have to land safely. Now we might be flying to the Bahamas today, to New York tomorrow, Canada the next day. So it's different scenery along the way and different things you have to look out for. Yeah. But it's kind of the same outline. Sure. And also it's to anesthesia provider specific. Some people come in and say, "Hey, I love endo.
Yeah.
I love doing this stuff." Some people say, "I love neuro. Put me in the neuro room." And then for those types of people that really like a specialty, you really usually see them stay in that same room with that same surgeon. Okay. Because when you get into some of the specialties, there's an intricate knowledge and a working knowledge between all members of the team where everybody gets comfortable. Oh, this is Dr. So-and-so. He likes to do this, so I do this. And it really makes for a smooth surgery. Yeah. And I mean, it's, just like any sports teams, people work well together and have a good rapport. Sure. They want to continue working together. Yeah. So I guess that's a roundabout way to answer your question, but you can kind of have as much, there's other people that say, hey, I want a little bit of everything.
Yeah.
I like a change of scenery. They'll go to 5 or 6 different facilities, rotate between them, doing a bunch of different cases. You know, let's say they're a very well-rounded person that feels comfortable in new environments and things like that. And then they can have as much variety as they want.
Yeah.
So there's a wide spectrum of what your experience can be, and that's kind of one of the things that are attractive about being a CRNA or going back to CRNA school is that you have the ability to kind of tailor your experience in a way.
Yeah. The only real experience I've had around anesthesiologist, I did an endoscopy assignment when I was a travel nurse. And it was very, to me, I mean, what I got to see was all kind of the pre-op. They would go in, talk to the patient and, you know, open their mouth, check their airway, ask them if they've ever had any problems with anesthesia, you know, let them know what propofol is. It was kind of, you know, but it seemed very cut and dry in the sense that, you know, we like always used propofol and, you know, maybe Zofran after. I didn't get to go in the room because I was an acute care nurse at the time. So I was doing all the pre-op stuff, like starting IVs and EKGs and things. But, you know, they would talk, you know, they knew all their history, but it seemed very cut and dry. And so to hear you talk about, you know, all of the things that you have to know and different types of procedures and anticipate the problems and all of that, it kind of took me aback to how like extensive, you know, and then I was just wondering, like, then do people, you know, specialize in one thing? Or they really, you know, some people are comfortable with just like a myriad of different, you know, surgeries.
Yeah. And so, again, it's kind of anesthesia provider, you know, specific when you refer to endoscopy. Those are minimally invasive procedures that have a risk profile that is that's not high. You would consider those low risk procedures. So they're put under a different magnifying glass, so to speak, where if somebody's coming for a heart transplant and they're in heart failure, well, usually you have some type of end organ failure as well. So if I'm taking a heart transplant back, I'm thinking about kidney function, liver function.
Yeah.
Okay, how is that? We're going to go on cardiopulmonary bypass. Okay, if we have some liver dysfunction coming off of cardiopulmonary bypass, we're going to bleed. Okay, so now I'm getting extra blood products together. You know, there's just more signs to read as you're going down the road, you know, so to speak, and you can kind of take any turn. You have to be prepared for that. So it involves just a little more scrutiny, whereas your low-risk procedures like endoscopy and stuff are generally straightforward with a minimal risk profile where things can go awry. Sure.
What do you think is some of like the most nuanced procedures that you've had to do, or like at what you know, like what does that end up looking like? Is it like, you know, responding to situations that you don't expect, or, you know, is it critical airways? Is it like types of anesthesia or doses, or is it like something completely different?
Probably some of the most nuanced procedures would be, off the top of my head, I can probably think of the thing that pops into my head first would be responding to an airway call on the floor.
Yeah.
Okay, so somebody, let's say it's a rapid response, it's not a code blue, because a code blue, we've already initiated CPR, so from an anesthetic standpoint, we're coming in to place an airway. You know, we're just securing the airway so you're not or you're not mask ventilating anymore. We're ventilating through an ET tube. Well, when somebody calls a rapid response and we show up, there's just a very wide range of, it's like a wide range of like situations you walk into, to where sometimes it's real obvious this patient needs to be intubated, and then other times it's very much nuanced of, okay, they need airway support, or ventilatory support, is that a BiPAP though? You know, are they stable enough where I can induce them enough to be able to provide appropriate intubating conditions and put this breathing tube in safely without causing harm to the patient? You know, if I'm called to to an overnight stay floor that does not have any equipment, okay, if I need an extra piece of equipment, do I have it available? Or do I need to call respiratory therapy, put them on a BiPAP, transport with them to the ICU, put an A line in, and then intubate with the intensivist there or an ICU nurse there? You know, so that's very much a nuance, and that call can really make or break a patient's hospital course.
Yeah.
You know?
Well, and I think that probably goes back to just your ability to plan and prepare, and
correct. And so, it's going to be, you'll hear it at nauseam in anesthesia school. It's like your pre-op plan, your pre-op plan, your pre-op plan. You know, and even though you're not going to the operating room, it's still the same assessment and anesthetic plan going forward. You know, the other thing would be probably an awake intubation anesthetic technique. That's a very much nuanced, and every provider has their special recipe that they like to use. And when you find somebody who has a good recipe, that is very much a nuanced, experience-related, like special recipe, you know. Because if you're doing an awake intubation, then that means either the patient has a neck fracture that you're unable to manipulate and put them in a good position to intubate, or they've got some type of external device like a halo or some other, contraindication to putting them asleep and intubating them in a traditional fashion. So you need this patient awake so that if we're unable to get our breathing tube in, they're breathing spontaneously on their own. And so those are very much nuanced situations that require like expertise.
Yeah. Oh my God. Bad day for that person. Awake intubation. I never even thought about those situations because I've never worked in a trauma ICU. That's so true.
Yeah. And so that's part of, anesthetizing the airway. It's getting them and goes back to pre-op planning. If I'm going to do an awake intubation on somebody, you really have to talk them and coach them through why we're choosing to do this, because it's the safest thing for you, and then B, here are the steps, so you know exactly where we are the whole time, and keeping the patient comfortable and not panicking is huge. If you get a patient that's uncooperative, then things can go south quickly, And both of these nuanced situations, you'll see a theme here is what you're afraid of losing the airway. And if you get into a situation where you can't intubate, can't ventilate, that's when disaster happens.
So then would you sedate them after, or they stay awake the whole time that they're intubated?
So once you have your breathing tube secured, it's in place. We have a good end-tidal reading. We had good visualization. The ET tube passed through the level of the vocal cords, and we have proper cuff inflation. We're happy. Our airway is secure. Then you'll connect them to an anesthesia machine and induce general anesthesia.
I see.
So then they'll be all the way asleep.
Gotcha.
Because the critical portion of securing the airway has been accomplished, so now you can proceed like normal.
And what benefits do you gain from an awake patient in those situations versus other than,
So one of the things for anybody that's doesn't know much about anesthesia, there's multiple parts, but without getting too specific, the main two things we look at are keeping a patient asleep So anesthetized, amnestic, they're not going to remember, and then we keep them not moving. Okay? So in a normal induction sequence, I'm going to push my propofol or etomidate or Versed and fentanyl if it's a heart patient to where the patient's asleep, but then I also have to paralyze them.
I figured it out
so
after I asked that question. I was like, oh, of course. Okay. You stop their respiratory drive when you have to say.
Now, there are hybrid techniques where we'll anesthetize a patient but not paralyze them. Okay? But those can be really tricky because you have a patient who's not paralyzed. So if for some reason the airway gets stimulated in any way and our vocal cords close on top of each other, then I'm not able to pass my breathing tube through, you know. And so that, when we're talking about nuanced, that's nuanced to the max.
So what type of, I mean, this is getting kind of technical, but like what's the concoction there that normally is like a good, you know, awake intubation plan?
So the recipe that I use, I actually picked up from, it's kind of a famous airway course that I highly suggest anybody who's doing overnight call where they're going to carry an airway pager or a code pager and be responsible for intubating patients on the floor. You go to, it's called the airway course. And so they have one for ICU, ER, and then anesthesia. And it's international anesthesiologists that put this on, and they give you a recipe. It's like, here's your 8 steps.
Okay.
You know, and so it's a mix of medications to help dry secretions because they act as a barrier to the numbing medicine. Use an appropriate piece of equipment called an atomizer. So you put your local anesthetic in this atomizer, hook it up to an oxygen source, and then you spray and numb up the back of the throat to eliminate the gag reflex. And then they suggest using it's a type of grasper with a cotton swab on the end, and they'll use that to anesthetize the tonsillar pillars. And then there's a lidocaine paste that they prefer. So you can see it's multiple steps, and you do them in a specific order to where you get global coverage and numbness, to where the patient's not panicking because you can feel pressure, but it's not painful. If the patient has a gag reflex when you go to try to intubate them awake, they're going to gag and ice water, and then that's when you get them trying to grab hands and kind of panic, because that's a very uncomfortable situation for that patient to be in.
Okay.
But the main thing is telling is you have to allow the medications to work. And so you tell them, we're going to give this medicine and this, we're going to wait and then test, and then wait and then test. And when we feel like we're not able to produce a gag reflex and all these types of things, then we'll go ahead and do our awake intubation. And that involves a bronchoscope and sliding your ET tube over the bronchoscope into the glottic opening.
That's so cool. So you've had to do that a few times?
Yeah. And when it works like it's supposed to, it's like, I mean, you look like a magician, and when it goes south, you look like the biggest idiot that doesn't know what they're doing. It's like you either hero or zero in a quick hot second.
Just cowboy in it. Ew.
Yeah, exactly. This guy over here, who let him come in there?
I want to get into a couple more logistics specifically about CRNA positions.
Okay.
So, and I know that probably varies depending on where you work, inpatient, outpatient, et cetera. But what are normal, normal hours, I guess, of CRNAs? Like, do you have to do on call?
So that kind of ties back in with your the previous topic we talked about as far as experience. It can kind of be what you want, and so every anesthesia group's different. Some have mandatory call, some don't. Some allow for 7 to 3 shifts, some 10-hour shifts, some 12-hour shifts, some 16, some 24s. Traditionally, an ambulatory surgery center is going to be 7 to 3, and they might have 2 people scheduled each day to kind of rotate through the cases that might run till 5 or something. So if somebody's looking at one main difference between anesthesia and ICU, it's ICU, you are shift work. That if you discharge all of your patients, you're probably going to get floated to another floor. You're not going to go home. Where in anesthesia, it's all workload based. Okay, so if our surgery schedule is just swamped for the day, there's a good chance that nobody's getting to go home early because you have this workload that you have to accomplish before we can go. On the other hand, if there's a light schedule, you can kind of knock those cases out and then maybe go help a sister facility out that might be short-staffed for the day. But it's all like workload based. And so I liked that because there were days where if you were having an easy day in the ICU, it was kind of like, all right, I can't speed up my time. I'm here this time to this time, where when you look at an OR schedule, you can say, okay, we're going to flip this surgeon from this room to that room. So if I show up early, I can pre-op my patients, I can get my medications together, I can be efficient with my time and my anesthetic technique, and we can finish early. And so that's very empowering to be able to say, hey, I can impact the workflow of my day. And that's something that's attractive to being an anesthesia
absolutely.
provider.
I'm sure that probably helps a work-life balance too. I mean, just being able to, get off at, know that you can be in control of, or somewhat in control of, being home at a certain time.
Well, and it's, some positions are allow for that, and then other places do say, but now we're a shift. This is 12 hours. That kind of thing. But there's some variation in that, so it's all kind of job specific. So when somebody graduates from CRNA school, that's part of the seminar that I give them is, here's your questions. Because somebody's like, what can I expect from this job? And it's like, well, what do you want to expect from it? You kind of need to set, this is, if you're, let's say you're a mom of 3 and you say, hey, look, I just, sacrificed 3 years of my life. I'm going to put my student loans on a plan that works for me. I'm not going to try to, knock this thing out in 2 years like some people. I want to live my life and I want to see my children. Okay, so that means I'm going to work 7 to 3.
Yeah.
Okay, then I would encourage her, okay, be honest with your employers or potential employers and tell them that. See if it's a right fit. And if they're like, I'm sorry, but our, makeup does not allow for that. Okay, cool. That wouldn't have been a good fit for her anyway. So she needs to try somewhere else, maybe a surgery center, something like that. But so there's just kind of a wide range of shifts. I know some people that'll do a 24 on Monday, and off on Tuesday, and 8 on Wednesday, and 8 on Thursday, have the week off. And then the next week, just do 7 to 3. And the next week, 2 12s and a 16. I mean, it just kind of depends upon the facility and how they're kind of set up.
24-hour shifts, does that include, would that be like an inpatient kind of, you're for 8 or 12 or hours of the day you're working, and then there's like an on-call portion, or are you just doing surgeries?
Well, you hope. You hope it's not for 24 hours. That's never fun. So what like a 24-hour shift will involve that. So like I said, it's all workload based. So let's say I'm doing a 24 on a Saturday. We all hustle, the patients show up on time, our surgeons aren't delayed. For any reason, we have all the equipment that they need, and boom, we're rocking and rolling, and we get done at 3 p.m. Okay. Then I'm on call from, let's say, that time until 7 a.m. the next day. So if nothing comes in, and you get to sleep in the call room, that's awesome. On the flip side of that,
if it's wild,
if you're in most places that do 24-hour call, they're either transplant centers or trauma centers, and you'll have a gunshot wound come in at 2 a.m. and then you'll work. The last when I was doing transplants, so the last 24-hour call I did, it was like, okay, this is karma. This is how it's gonna go. I did 3 kidney transplants, a heart transplant. I relieved a resident on a double lung transplant, and then I was bringing back a type B dissection when my relief came at 7 a.m.
You're like, never again.
Yeah, I was like, this is one for the books for sure.
Oh my gosh. I don't know how you stay awake. And you're on, it's not just, in such a important.
Oh, and now too, to give everybody a sense of peace out there that just heard that and got real anxious. Like, you have teams in place, where I was at doing transplants, we had just a fantastic anesthesia team. Our anesthesiologists were absolutely wonderful, and we really approached it as a team. So we give each other breaks, and we help split up the workload where it's manageable. And there are times where you kind of have to be honest with yourself and know your limits. And if you need a break, to say, hey, look, I need a shot of water. I need to grab a cup of coffee and just kind of decompress for a minute, and then I can hop in there and get back to it. And you go, do the same.
Gotcha. I see. I was in reading the seminar that you made too. I was looking at the difference between 1099 nurses and W-2. So can you speak to that a little bit about having the option to do one or the other, and maybe like a couple pros and cons for both?
Sure. So essentially what that refers to is for anybody that is not familiar with the topic, it's how you're classified as an employee. So if you're a W-2 employee, your employer is going to withdraw your government taxes and pay them on your behalf. Okay, so that's the one we sit down and we look. And okay, I grossed $100 and then I paid in $80 to the government. I got 20 for myself. That's how it feels. You're like, wait a minute, I work more hours
never being a CRNA,
time and I got like less money. How did this doesn't work out? So, and then that's a W-2, and then contrast that, you have a 1099. And 1099, you're just paid a straight flat rate. No taxes are taken out. So you're responsible for submitting or paying in your own taxes quarterly and things like that. So there's pros and cons to each. And you really have to kind of evaluate each job offer independently and then side by side to figure out, okay, how do they stack up? Because benefits, you're not provided any benefits on the 1099. It's just straight money. And so it's important to know that, because a 1099 offer is going to look much more attractive because it's a larger number. But then, okay, well, what is the cost of me providing my own insurance? Okay, if I'm a single person in my late 20s, that's going to be a minimal cost, maybe a 1099 option. Okay, if I'm closer to retirement age and I've got a freshman in college and, a family and multiple dependents, then maybe having a robust benefit package as a W-2 employee might be the way I want to go, So those are some of your pros and your cons. W-2, pros, It's easier. You don't have to worry about paying in taxes yourself. The company's going to do that for you. You get a robust benefit package. It's simple, it's straightforward, it's easy. 1099 is more complicated. Now, if you work a 1099 to your advantage, you can have more tax write-offs. And some people will argue that if you set 1099 up correctly, it's much more lucrative and you can get tax advantages and savings that way. So that's your main difference between 1099 and W-2.
And are both of them, I mean, are you still in both part of an anesthesia group? Or like with a W-2, are you hired by, you know, the hospital, and 1099s, you're more part of this independently contracted group?
Again, not to give you the same answer like 3 or 4 different times, but it kind of depends.
Sure.
It's all anesthesia group specific. I'm seeing a trend now away from 1099 employment as a full-time anesthesia employee of an anesthesia company. Usually that's traditionally going to be a W-2 position. And so most of the time, it's kind of layman's terms. You'll hear somebody say, oh, I'm doing 1099 work. That usually means they're either doing a locums assignment, some type of travel assignment, or they're just picking up some extra shifts to fill in an area that's uncovered. So most of the time, you're, I don't know any anesthesia group off the top of my head that is hiring full-time people just on a 1099 basis, unless you're in, let's say, an all CRNA practice in a rural area of some sort.
Okay, cool. Very good. I wanted to go through, you know, in talking about the seminar that you had come up with, there was a few things that go through kind of tricks of the trade for CRNAs. And as I was going through it, I was like, this is great information for not only just CRNAs, but just, you know, professionals trying to, you know, set themselves up for success in the regards to like respect and communication. So in thinking about characteristics that would make up a good CRNA, can you touch on some of those tips for success that you, and kind of advice that you would normally give to your new CRNAs?
For sure. So one of the main characteristics that I try to talk about is being humble and honest. And so we come fresh out of school. It's not you know, dissimilar to being a brand new ICU nurse. Somebody's going to come in, a cardiologist is going to come in, he's going to rattle off something, he's going to ask you some questions, and we're going to be like, I'm following you, I know where you're at, and I have no clue what we're talking about. You know, so that's one of the things that I try to tell everybody is, you know, there is no fake it till you make it in anesthesia school, you know, or an anesthesia practice. If I don't know something, I need to be open, honest, and humble, you know, and they're like, well, I'm going to look like an idiot. It's like, that's better than hurting somebody, or, you know, not establishing a level of trust, you know, and that's what I try to tell people that are starting out is you're going to get more respect by saying, please forgive me. I know I should probably know this, but I'm completely ignorant to what you're talking about. Would you mind educating me real quick? Most of the time when you take an approach like that, you establish a level of trust of, okay, this person is being honest with me, allowing themselves to be vulnerable, but creating a teachable moment for themselves. And then that surgeon, let's say I'm talking to a surgeon, that surgeon knows, okay, when they're in my room, I'm not getting any BS. You know, they're going to be honest with me, and they're not going to be just going through the motions. Right. You know.
That's really important.
So that's one. Another that I just harp on all the time is having a good work ethic. And what I mean by that is somebody is purchasing time in our day. And so we need to be using that as efficiently as we can. You know, and in anesthesia in particular, it matters because if you can run an efficient room, the day is going to go smoother and you're going to finish earlier. Okay. And it sets a mindset of, okay, I'm coming in on the day and I'm setting the tone. We're going to come in, we're going to work hard, and then we're going to go home to our families, you know. And the probably other third thing that I really harp on is being a good teammate.
Yeah.
All of these things sound just so basic and foundational, and they really are, but they cannot be overstated.
Yeah.
You know, and what does a good teammate look like in an anesthesia group? Okay, not complaining about assignment. You know, it's easy if you start looking, you know, in the ICU, it's the same thing. I've had this patient 3 days in a row. Who's picking on me? Why am I in endo again? You know, I did that yesterday. You know, and it's you know, just playing our part as a team, making sure that if I've got some downtime, let me go find somebody who's in a busy room and offer them a break. Maybe they need to step out, make a phone call, get a shot of water. God forbid, have a decent lunch break. You know?
Yeah.
And so if you can put those three things together, that's really going to take you a long way, especially in the first 6 months on the job.
Yeah. One of the things that resonated with me was the point of taking extreme ownership and accountability of your actions, something that you would put in your PowerPoint. I just thought that was so, I mean, it's very much, you know, a part of a well-oiled team, and being completely honest and transparent is figuring out exactly where you went wrong, and the fact that you are accountable for those things that have happened. Or even if you felt like, you know, other people were too, understanding what your piece was in, you know, that puzzle and order, you know, to troubleshoot for next time. I think that was such an important thing to take away.
Absolutely. I couldn't agree with you more. I wish I could take credit for that, but that's actually Jocko Willink, who was an ex-Navy SEAL. He retired from the military, now he does like leadership conferences. He has a book called Extreme Ownership. And the idea of that is, if I approach a patient as, this is my patient. If I approach my job as, this is my hospital. How would I treat this patient if my name was on the front of it?
Yeah.
You know?
Yeah.
And then also looking at problems in that same manner of, well, that was an ancillary service. That doesn't have anything to do with me. Well, no, that was my patient. Did I communicate with them appropriately? Did I provide rapport to where they understood why we were, you know, implementing these measures and why it was not appropriate to stop those medications, you know? And it kind of comes also with the idea of like, if not me, then who? If not now, then when?
Yeah.
You know? And those are the two questions. No, if it doesn't have to be anybody, it's going to be me. When? Now. You know, we're going to address it, and I'm going to take ownership of it and try to steer the ship in the right direction.
Yeah. I think, like I said, I think that's one of the biggest things on a well-oiled ship is everybody taking accountability in that way, and things just flow much smoother instead of, you know, people that kind of float in and out. It's kind of hard, you know, might not have that same like work ethic. And so just instilling that early on, I'm sure your rooms flow much smoother, and then you have a much more efficient.
And if you have a team, especially a team, not just one individual that really takes on that extreme ownership, and you have a debriefing after an event. Let's say it was an event that truly and honestly was going to happen no matter what. Yeah. Okay. Well, if we take extreme ownership of it, and we say, I could have done it, maybe this would have, you know, played a different part. If you have 5 people doing that, I guarantee you're going to stop an event from happening for some other patient in the future. And everybody's going to just have a better rapport going forward. Yeah. You know, our process is going to be better. And 9 times out of 10, you'll find an ancillary side piece of information that sparks an entire protocol and drives, you know, efficiency in another way.
Yeah.
You know, you're like, we weren't looking to find this, but we noticed that on all of these we were doing X. Yeah. And then, so now we're doing this, you know.
Yeah. Just makes everybody more comfortable and feel safer too, I'm sure.
For sure. And it creates an environment where people feel like they can openly and honestly discuss what's going on, and they don't feel, you know, as nurses, for whatever reason, it was always like just punitive measures, like just burned in our brain, you know, and it's like medication errors, you know, it's gonna happen to you, you know, and like, you know, and it's like, you're always afraid to like discuss, you know, some things that it's like, no, I don't want to say anything, like, you know, but the way to improve these things is to openly and honestly discuss them. You know? Yeah, absolutely. Makes a good team.
Well, I think we are going to end it here. We have covered so many good topics about CRNA. Thank you so much for coming on the show with us today.
Thank you for having me.
This was such a great episode. We have a lot of gems that I'm sure a lot of people will enjoy. So I appreciate your time, Blaise.
Thank you again for having me. It was a pleasure.
That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aiden Dykes for the music and editing. Until next time, take care of yourself.